So as Dr. Patel just told you, I'm one of the interventional physiatrists at ONS, which means I stick needles in people for a living. So I do lots of different kinds of shots. So usually I get questions from patients whenever there's new technology out there. Can you do that? If you can do that in the knee, can you do it in the back? And vice versa, that kind of thing. So today what I'm going to talk to you about is platelet-rich plasma injections and for low back pain. What is PRP? I know that Dr. Kessler already went through it a little bit. I'll just touch on it again. PRP is a procedure that's been done since the 70s in horses and dentistry. We've been doing it in musculoskeletal field since probably about 10 years now. The most common case people remember is Hines Ward before the first Steelers Super Bowl they won recently. Had it done for his MCL and played and did great. And so that brought out a whole bunch of interest in it. It is still not FDA approved, so it's still experimental. So it is unfortunately not covered by insurance, and that limits its usefulness not because of its effectiveness, which I think it is effective, but because it is a paid procedure that you have to pay out of pocket. We use it commonly for tendinitis and ligament tears. Typically, we try to heal them through more conservative treatments, physical therapy, anti-inflammatory medicines, rest. If it doesn't work, then we go on to that. There's actually evidence out there that it may be more effective than steroid for lateral epicondylitis. In fact, if you do steroid first, it looks like you may inhibit the use of PRP later on for lateral epicondylitis. So it's an emerging technology in its own right. As Dr. Castle talked, there are lots of different systems out there. So all of them are the same. So no matter what system you use, all of the research shows it's the same effectiveness. Different amounts of blood are drawn, you spin in a centrifuge, you pull out the concentrate with the platelets, you inject into an area under aseptic technique, and then what we've been using is ultrasound to make sure we're in the right spot. So guidance does seem to help you out. And here we go with, well, that does not, how do I get the mouse? There we go. So the plasma's on the top. The buffy coat is here with most of the platelets, and then the things we don't need are down low. So the question then is, can you use in the spine? And so one of the areas that's being looked at is lumbar degenerative disc disease. It's a very common spine problem. It's a combination of lots of things as to what happens to people. There's a genetic component. There are patients out there that happen to get it because their family has it. My brother and I had 2 disc herniations at 18, the same age. We're completely different builds, we're completely different activity levels, but there's a genetic component to what's going on. There's a mechanical component, there's trauma that can be a problem. Systemic, infections, biologic, there's sort of chemicals. What happens is this, the disc is a jelly donut, and you get tears in the donut part of things, which is the annulus, and that leads to degeneration. There's poor blood supply in that disc, so it makes it hard to heal, just like the lateral epicondylitis. If we x-ray everyone, as we get older, we'll see it very commonly in people. It does not mean it's always causing a problem. It's there. But if it does correlate with someone's pain, then we know that we think that's the area. It typically causes back pain. It may cause leg pain also. But for most people, it does cause mostly back pain. Here is a picture of a healthy disc. Annulus on the outside. Nucleus in the middle, so that's the donut. There's the jelly part, and here is a tear in the donut with the jelly part popping out. That is disc herniation. Then what does it look like on MRI? Well, MRI, this view, white is water. So this disc has a lot of water in it. That's a normal disc. As the disc gets worn down, it loses water, it loses height. Here's an even more degenerative disc with a little bit of a disc herniation also there. This is a picture of what's called an annular tear. And what an annular tear is just an isolated tear in that donut part of the jelly donut. It is of unknown clinical significance, which means we don't know what it means. But if someone has pain and it fits with the area that's causing the pain, then we think it's causing the pain. There are people out there with it with absolutely no pain. So just because you have it on MRI doesn't mean it's a problem, but it certainly could mean that that's what's causing it, their pain. And here it is right here, that little white spot in the disc. You can see here, everything's nice and even, and here is a little bit of a dark disc with a white spot. That is the annular tear. This is the meanest thing that I can do to someone. This is what's called discography. What discography is when you stick needles in people in their disc, try to reproduce their pain. This is contrast into the disc spaces themselves. This is what a normal disc looks like. So nice and sort of contained. Here, as there is more degeneration, you can see the contrast leaking out. And here, actually, it's leaking all the way outside of the disc itself. So it's one of the ways that we can prove a disc is not only degenerative, but if it reproduces their pain, that is the source of their pain. It's a controversial test, which means that there's literature out there that says it's not effective. I think the hardest part of the test is operator error. In other words, you have to be able to convince a patient that they have you stick a needle in them, say, all right, you have no pain now, and now I'm going to hurt you, and you have to figure out, is that your pain? It's hard when someone has pain to tell you, ignore all your other pain, but that's part of the test. That's why it's hard to do. So then the question is, can we use PRP in patients with degenerative discs? Obata in Arthritis and Research Therapy, 2012, did a study using animal model. He used a rabbit. They essentially stuck needles in the disc, caused disc degeneration, and then used PRP to inject in. They used PRP relastase and tried to look and see what happened to the degenerative disc. And they found out that actually the disc treated with PRP did have a restoration of disc height up to about 90% of normal. So they looked more normal after they were done. And they had more chondrocyte-like cells in the PRP discs. So Dr. Lutz at HSS then took that and decided they're going to try to do a double-blinded, placebo-controlled study of PRP into discs, which is a hard study to do because you're trying to convince someone to do a procedure and not know if they're actually getting the real procedure or not. They did a single level, so it only was with a single level, and you had to have an annular tear, which meant it wasn't just discs that were worn down. It had to be a degenerative disc with an annular tear. They confirmed it with discography to make sure they were in the right spot. And then they randomized them into PRP or extra contrast. So you basically, as a patient, you're laid on the table, they put the needle in the disc, and then they said, all right, we're going to confirm that's the area that's your problem. If you were confirmed, you didn't know if the next fluid was contrast or PRP, but they then checked to see how you felt down the line. The results are very preliminary. So this is not a fully published study as of yet, but they did release the preliminary data at the ISIS conference, which is the International Spine Injection Society in New York City. They did 31 patients. They followed up on 30 of them, which is actually a pretty good follow-up. They found that the statistically significant reduction actually in pain, I have a typo in here, they increased their physical functioning, they decreased their pain measurement at 8 weeks. So at 8 weeks, it looked like people were feeling better, doing more with less pain. They followed them through for a year, or up to a year, in the majority of patients, and found out that there's a higher patient satisfaction with the PRP group. 61% were satisfied as opposed to 11% versus placebo. So that's a pretty good number. Obviously, not everyone. 61% is not a slam dunk procedure, but that's still pretty good compared to 0%. It's still very early into the study, so we still need some more evidence, more studies need to be done. I'm certainly not itching to be the first kid on the block to do it because it obviously, until we know what the long-term effects are, I'm a little nervous, but PRP has been done for a while. It's very safe. There's no negative side effects ever reported with PRP because it's your own body's natural stuff. It's an encouraging study, though. Again, the problem is you need to have an annular tear, not just a degenerative disc. We need long-term outcomes, and the problem with injecting into discs is if you do get an infection because of the blood supply being so low, it can be catastrophic. So one of the things that you have to be very careful for is do it in an extremely sterile environment. I think that's it. Thank you very much.